Many members of the general public have never heard of this condition.
Approximately 400 million patients globally have COPD.
We need to catch patients before they've lost half of their lungs.
What gives you hope that we will make change?
We've got real momentum now in treating COPD and the opportunity to change these patients' lives.
Hello, and welcome to Behind the Science with GSK and me, Dr. Kat Arney, where we unpack how today's discoveries are shaping tomorrow's health. Today, we're exploring diseases that affect a fundamental aspect of life, breathing. Conditions like asthma and chronic obstructive pulmonary disease, or COPD, limit the ability of our lungs to simply move air in and out of our bodies. And this can affect many aspects of daily life: exercise, work, sleep, and much more. More severe respiratory attacks can send people to hospital, often repeatedly. And once you've been admitted, you have a 1 in 4 chance of dying over the next year. A lot more can be done to understand and control COPD. And to explore what that looks like, I'm joined by my expert guests, Dr. Kaivan Khavandi. He's the Senior Vice President and Global Head of Respiratory, Immunology and Inflammation Research at GSK, and Professor Dave Singh, who specialises in respiratory pharmacology at the University of Manchester. And he's been the principal investigator in more than 400 clinical trials, including studies developing new drugs for COPD. Hello.
Hi.
So let's kick off. Kaivan, you've been working in the area of respiratory medicine for a long time. Can you give us an overview of respiratory diseases? It feels like a big bucket. So what conditions are we talking about here?
Sure. So respiratory diseases are common and they pose a significant consequence in terms of how patients feel, function and survive. You can broadly think about respiratory diseases such as asthma and COPD, chronic obstructive pulmonary disease, the really key diseases that affect patients at high prevalence. Again, asthma is an area that's relatively mature in terms of management and therapeutic development. And what we see now is that the outcomes for patients with asthma are very good. The expectations of new therapeutic solutions is very high. In other areas like interstitial lung disease, where you've got fibrosis of the lung, unfortunately, therapeutic solutions have been slower to progress, and we really haven't seen transformative medicines yet. And COPD is perhaps somewhere in between, where there has been significant progress, but unfortunately, the morbidity and mortality for those patients is still very high.
Kaivan, you've mentioned asthma and COPD quite rightly as the two most common diseases. And while I think the public all know and have heard about asthma, COPD is something that people don't know about. COPD, chronic obstructive pulmonary disease, if you asked 10 people on the street, what is that? I think half of them wouldn't know. And it's a disease that happens after years of exposure in most people to particle matter, commonly smoking. Pollution's another cause. And after decades of exposure, it damages the lungs. So that damage gives people symptoms. Because it takes years of damage, years of exposure to get the damage, it's a disease that happens later in life. It can start in your 40s or 50s. It's diagnosed a bit late commonly. There's a lot to do to educate the general public about this common disease that is a major cause of mortality worldwide.
So when we're thinking about COPD, what is the scale of the problem? What's the burden that is putting not just on patients, but more widely on the healthcare system?
Yeah, the scale of the problem is enormous, actually. So approximately 400 million patients globally have COPD. The prognosis for those patients, unfortunately, is very poor. The disease course is progressive. That progression results in high morbidity, high strain on healthcare systems. So these patients come to the emergency departments. Pretty terrifying experience, both as a doctor and certainly as a patient, when you arrive at A&E really short of breath and sometimes requiring critical care quite quickly. So the scale, both in terms of prevalence and at the level of an individual patient, is very significant.
I was really surprised to learn that there's 3 million deaths in 2021 from COPD globally. Now, that's double the number of deaths from lung cancer. We all hear about lung cancer, we all hear about asthma. Why do you think that COPD isn't as well known?
So the name COPD doesn't lend itself.
It's not catchy.
It's not
I will
catchy.
say.
Yeah. But there are other reasons as well. We have underdiagnosis of COPD. So when people are diagnosed, it's usually quite late on in the course of their disease. So it can be seen as a disease where you've done this to yourself. You've smoked. There'll be a stigma associated. So people don't like to talk about it. And then if it's not well known, if you were to talk about it, the people you talk to may not know anything about it. So there's this whole lack of knowledge, stigma, and people feeling they should just live with it and keep it to themselves. It's not something that I would say public health across the world and globally healthcare organizations have placed near the top of their priorities. So that doesn't help as well.
And we're also seeing, I understand, like an increase in the rates of COPD, and this is going to put a massive increased burden on healthcare given the scale of it. So do you think that we should be taking it much more seriously as a global health condition? And are there things that are increasing the rates?
So absolutely, we should be making more concerted, proactive efforts to raise awareness, increase early diagnosis. And so with COPD, I really think it's a case of helping understand the scale of the challenge, ensuring earlier diagnosis, and also having therapeutic solutions that are going to be relevant in being disease modifying earlier in that trajectory. As regards the incidence increasing, of course, smoking is a key risk factor. In some regions, smoking is on the decline, but that probably is balanced against increasing levels of air pollution. There are some risk factors and triggers that are probably not fully understood yet. So certainly at the moment, we haven't solved COPD. And actually, I think with an aging population and increasing comorbid disease, I think that the phenotype or the way COPD presents might become more challenging.
There's not sort of a blood test like you might have for some conditions. You can't have a blood test and go, yep, that is COPD.
No, we rely on this breathing test because that's where the damage is. And what we're trying to do is measure whether the function of your lungs has been decreased. There are other tests of the lungs. So there's a CT scan. So people get them now for, if you're a smoker and you're age 55 or over, you might be receiving a letter to go for a CT scan. And that's looking to see if you've got cancer on your lungs. But you can also pick up COPD that way. So there are other ways, but it's all about looking at the lungs.
And how does this manifest for someone? What do they experience in their daily life if they have COPD and it's maybe getting worse?
The symptoms of COPD are often played down before the diagnosis happens. People can quite often lose 30, 40, 50% of their lungs before they actually go to the doctor because of breathlessness. And then you do the test and you say, look, you've got COPD and you've probably had it for many years. You ask me, what do the patients suffer with? Well, they're all different from one another. The technical term we use is heterogeneous. That means if 5 patients come and see you, I guarantee they'll all complain of slightly or dramatically different things. So the symptoms they have, the common one, the most common one, is breathlessness. And then they also complain, some, of bringing up a cough. They're the things we often ask about as doctors. COPD patients also suffer with these sudden worsenings. So we have a technical term, we call them exacerbations, that their breathing over a day will suddenly get much worse. They can lead to hospitalization, and there's a mortality associated with these events. And one of the aims, one of the goals of management is to prevent these.
If you prevent exacerbations, you're going to improve survival, and maybe trials that are able to have the courage to test for survival might be the clearest way where you can raise that awareness that actually, if you're not proactive in management, then these patients are going to have a very poor prognosis, and we can fundamentally shift their mortality curve to be beneficial.
So we see the impact of COPD in daily life, in breathlessness. But what happens when this gets more serious, when it does get exacerbated?
Sometimes it's difficult to tell whether a COPD patient is just going through a natural variation from day to day.
A bad day.
Yeah, not every day is the same for a patient with a chronic disease. But sometimes there'll be an event, an infection, a change in the atmosphere that will make it dramatically worse. So the respiratory system gets worse. Patients might become more hypoxic, so lack oxygen. That might send them to the emergency room. They may end up on the ward, on intensive care. So these can be very rapid declines for patients that you need to recognize early on. Across the world, I don't think we have the healthcare systems awareness and implementation of how you can have active responses to best protect patients. So the patient is lacking oxygen. There's what we call inflammation at that time. So inflammation in the lungs and in the bloodstream. This is increased activity of white cells and other mediators that might lead to a heart attack. And so the immediate 2 weeks after, 30 days, there's a huge increase in your risk of having a cardiovascular event. So that encompasses heart attacks and things like irregular heartbeat, atrial fibrillation. But that risk can be present for up to a year afterwards.
So if someone does end up in hospital with a COPD exacerbation and they're sent home, I'm thinking of the contrast with something like a heart attack. You're sent home with a program of, you're on this treatment, you've had this, you're going to do this. Does that kind of thing currently happen if someone has gone into hospital with COPD?
Yeah, I think the parallel with heart attacks is interesting, because if you think about what happens when you show up to a hospital with a heart attack, there's a pretty military operation to get you into the cath lab, and then you go home with a cocktail of secondary prevention medicines that address multiple modes of the underlying risk. If you show up to the hospital with a COPD exacerbation, there is obviously an effort to ensure that you're able to leave the hospital. Unfortunately, the current solutions to ensure that you don't come back to hospital are somewhat more limited.
So it seems like the really big goal is keep people out of hospital.
Yeah, agreed. Totally agreed. But what you said, Kayvan, is interesting, because there's this interplay, I think, between scientific advances and how they then translate into what we do in hospital. So if we dial back a couple of decades, if you were a COPD patient and you were sat at home having an exacerbation, you and your general practitioner would probably think it's just a chest infection. Now we realize it's not just a chest infection. It carries this huge risk. And we're at that stage now where we realize we need strategies to reduce the risk. We need to generate the evidence to change practice.
Is there something here about the awareness? We've had a lot of awareness of, if you're having a heart attack, do this. If you're having a stroke, these are the symptoms, be aware of these things. Do we need to sort of make, for want of a better way of putting it, make a COPD attack a thing, that this is as serious as a heart attack?
Totally. There needs to be awareness. We're talking here about the convergence of a number of things that we need to do in order to improve practice. There's awareness, generate evidence, and then change practice. They all need to happen. We talked about statistics for the number of COPD deaths across the world. It's actually an underestimate, because patients might, when somebody passes away, on the death certificate, there's the doctor will write down the likely cause of death, and quite often it will be a cardiovascular cause. But one of the underlying provoking reasons for your heart attack was you had COPD.
Let's dig in a bit more about what's actually going on here in the development of the disease. So you have lungs, you have something's irritating those lungs, it's causing inflammation. What is actually going on in the biology as that inflammation is happening, Kaivan?
The short answer is it's highly complex.
Oh, no.
and it varies from patient to patient, unfortunately. And even at the level of an individual patient, it can vary throughout the course of their disease. The origin of the disease is a repeat injury to particulate matter that the body probably tries to respond to appropriately, but with chronic exposure becomes inappropriate. And so you start to get this bronchoconstriction, you start to get destruction of the distal airways, the smaller airways further down the airway. And then you start to get inflammation, which of course inflammation is not a bad thing per se. Inflammation is the body's response to injury and wound healing. But with chronic exposure to inflammation, it does become pathogenic and starts to cause progressive disease. And so what we've now started to characterize, of course, is the structural abnormalities that we observe in COPD, but also what types of individual cell types are driving different modes of inflammation at the level of an individual patient or a cohort of patients that might associate with certain characteristics, and then what those different types of inflammation resulted in how patients feel, function, and survive. And the advances that we've seen in the last 10 years is that one type of inflammation, which we call eosinophilic inflammation, so related to one particular type of white blood cell, has now become tractable, by which I mean we've developed targeted therapeutic solutions that's able to dampen or reduce that type of inflammation. And when you do that, you are able to reduce the likelihood of having an exacerbation.
It must feel quite frustrating if you have one disease, you know what's causing it, you can target it. But it feels like COPD, we've got a lot of differences between patients, we've got a lot of different underlying mechanisms, and then also we've got other health conditions layered on top. So how are all these sort of interplaying?
Complexity is the right word.
It's annoying, isn't it?
It's a challenge. Complexity is common in many human inflammatory diseases. So I think COPD is probably at the more complex end because it's caused by injury, whereas a lot of other human inflammatory diseases are what you might call autoimmune diseases, where they arise internally.
And so it does feel like we're getting this broader, more sophisticated understanding of almost not just what's going on in the lungs, but what's happening to the immune system and maybe the body more widely as well. Sort of, are we going from seeing this just as a disease of parts of the lungs to more of a disease of the body, more of a systemic problem?
Absolutely. I mean, if you think about how these patients present, it's an integration of different organs within a system. And also the reason why it's very likely that really effective treatments, transformative medicines, are going to require a combination of approaches. And we've seen that in other disease areas.
So Dave, let's talk for a minute about the way that COPD is treated to try and keep people out of hospitals. So someone is diagnosed with COPD, what that looks like, and then what are the treatment options? Has this changed over the past, say, 10 years while you've been practicing?
It has changed. It's important for us to recognise treatment involves medicines, pharmacological, and there's non-pharmacological management. So treatment has to be holistic for the patient. So non-pharmacological management, which is a cornerstone, involves things like supporting patients to stop smoking, encouraging them to be physically active, making sure they get their vaccinations. So that there's that whole chunk of common sense stuff that is essential. Then when we move on to pharmacological management, and you should do both side by side in parallel, the advances have predominantly, until the last couple of years, been in inhaled therapy. So we previously, we have three main classes of inhalers, two that we call bronchodilators, they open up the airways, and one inhaled steroids, they try and deal with the inflammation. So we've used them for years without really having a good evidence base for who responds best.
Just like one size fits all, right?
Exactly. Now we have a much more aggressive and personalized approach. So it comes back to this heterogeneity, difference between patients. So personalization, finding the right treatment for the right patient, that's been a huge advance. So we have this I would call it a foundation, where patients should be on the right inhaler very quickly. And then after that, in the last few years, we've had positive data for what you might call add-on treatments. And again, they are personalized, and that will help us pick the right treatment for the right patient.
And we're now seeing a new class of treatments coming in, and these are going beyond inhalers to treatments that we would call them biologicals. These are antibody-based drugs. So tell me a bit about these. What are these treatments, and how are they different from the inhalers that have conventionally been used?
Yeah, so GSK has been part of this treatment journey from really its origin, so has contributed to the development of both reliever inhalers, maintenance inhalers, bronchodilators, inhaled corticosteroids, and combinations thereof. And in the last really 10 years, we've started to develop monoclonal antibodies that are more targeted, injectable therapeutic modalities. They're able to bind to specific receptors or ligands, to use the term, the things that bind to those receptors, to stop signaling that results in a particular type of activity or biological function. And so in this instance, those receptors result in eosinophilic inflammation, and those have now resulted in successful therapeutics that have been approved for the treatment of both asthma and chronic obstructive pulmonary disease when you see increased levels of that type of inflammation. The types of data we see in trials is maybe between a 20 to 30% reduction in the risk of exacerbations. So that's very important at the level of a patient, but clearly we can aim even higher. And that is only relevant to certain patients that have that underlying type of inflammation. And just again, to put that into context, the first biologic in COPD was approved in the last 2 years. The second was approved only last year. So this is really, I hope, the start of advanced therapies for COPD.
And in terms of what outcomes look like for patients, what does good look like from a patient perspective, from controlling their COPD? What are patients expecting these treatments to do for them?
There's a lot more optimism now that there's something that we can offer. So that patients are aware now that there's potentially a brighter future. And this is a huge change for us to be able to say to patients that we can offer you more. It's bringing a lot of optimism. I mentioned before that there's been a pessimistic view of COPD treatment. And I think that arises from the fact that doctors, but maybe not so much patients, but doctors want treatments to achieve huge improvements, because that's what happens in other conditions. You can give a treatment and a patient will come back and say, I feel completely better. I have nothing, no symptoms. So if you're a COPD patient and you only have half of your lung function left, and that's a common thing, half of the lung is not working properly, but you're still able to get to the shop. You're still able to go and visit your family. You're still able to walk around your house and do everything to care for yourself and do what we call your activities of daily living. If I, as a doctor, could promise you that you won't end up in hospital, and in 1 year's time, you will still be doing what you'll be able to do. For a patient who last year was in hospital and feeling worse and worse, most patients would say, thank you, I'll take that.
Yeah, I'll take that. Absolutely, for sure.
And there's a common word we use, stable. Mm-hmm. So I think the target in COPD is to make patients stable. Now, we of course, would love to improve patients as well, and that's still on the table. To do that more effectively, we need to make earlier diagnoses. We need to catch patients before they've lost half of their lungs.
Can I add a figure that Dave and I are well familiar with, but others might not have seen, which is if you look at a graph where you've got the time course of a disease and you've got lung function on the other axis, what you often see is almost a staircase-like visual, which is related to every time someone exacerbates, they get this irreversible step change in the underlying lung function. And so obviously if you can project back earlier in that process and intervene before they've suffered from several irreversible step changes, i.e. the prevention of exacerbations, you've really changed the course of their disease.
Where do you want to be in 5 years, Dave?
For me, it's a natural progression of what we're doing already, the advances we've made. So we're more aggressive now in terms of getting the patient at an earlier time in their disease on the maximal pharmacological therapy for them. We've got a higher goal. We're aiming higher. We want no exacerbations. Previously, exacerbations were acceptable. And this is a condition where we need to personalize the treatment. So they're the three pillars for me. It's a journey we're on, and we're accelerating that journey. We're shifting the conversation towards a realistic one where a healthcare professional can have shared goals with a patient. So to say to a patient, these are things you need to do. So can you stop smoking? Can you stay active? Can you make sure you get your vaccinations? Can you eat well and maintain your nutrition? That's your part of the bargain. Now, my part of the bargain is that I will make sure the physiotherapist sees you. I'll make sure you know how to use your inhalers. I'll make sure that you get the right treatment as soon as possible. It's a shared partnership. And so then that's reality, rather than the patient expecting that there'll be a miracle cure, because there isn't. For the majority of individuals, you cannot get them back to where they used to be.
Kaivan, what gives you hope for the future of COPD?
So I think it's a combination of not just the scale of the problem, but the fact it's tractable and we can treat these patients, and we'll continue to develop more innovative solutions if we're able to identify them earlier in their disease trajectory, and we continue to invest in human biology and therapeutic solutions. So it's a serious problem, but actually I think the future's bright for these patients. We've got real momentum now in treating COPD, and there's scientific breakthroughs which we will translate to patient benefit. A company like GSK is large. We do have significant resources. I cover all areas outside of oncology and vaccines. So that's respiratory, hepatology, kidney disease, vascular, neurodegeneration. COPD is at least the co-primary area of focus for us because of all the reasons we described, because there's so much more innovation to be had, because of the unmet need and the opportunity to change these patients' lives. That's something that I'm really passionate about. And I look forward to working with investigators like Dave to be part of that solution.
We could talk about this for a lot longer, but unfortunately, we do have to wrap up the discussion now. So I would like to say a very big thank you to my guests. We have Kaivan Khavandi from GSK.
Thank you.
Thank you. And Dave Singh from the University of Manchester.
Thank you.
Thank you. Now, if you enjoyed our conversation, please do leave us a comment or a review. You can share this podcast with someone else who might like it too. And until next time, take care and stay curious.